Good evening to all of you. Sorry, we are running a little late, quite late, sorry, and also I think the air conditioning is not helping us. So we'll start off very fast. I think the introductions have been made already. So, first, so far, I think all theory has been spoken since morning. Now, practically, now what we face in the ground, what we are having difficulties or challenges, and how we have solved those challenges is what we are going to talk about now. We have a very good mix of speakers. We have two large corporates heads here. One, Dr. Rohini Sridhar, has been in this field for several years, and she's been also in the digital space in Apollo hospitals. Dr. Ayyappan is also got a lot of digitization work at Kaveri Hospital. Dr. Mukesh Mohan from Trichy. Rather, he's a robotic joint replacement surgeon, so he is into some form of digitization. And Dr. Prabhakar is from Erode, and he's also. So we'll get a varied opinion from everybody, from corporate hospitals to long-term corporate hospitals to eventually tier 2 and tier 3 people, how we have challenges in this. And so let me first start with Dr. Rohini Sridhar. Your organization is several years old. You have a lot of goals and mission it's been there for several years now. So digitization, has it changed anything, or did you have to do something else to align with your goals and mission?
Thank you, Satish and CII. Great to be back on this platform. And at the outset, I like to partially agree and partially disagree with Satish. I think the challenges remain. I'm not sure that we've solved anything. I would say that we are, maybe 2 steps ahead in the journey of where we want to go. Now, I will, when you look at digitization, and I was fortunate to attend at least a couple of sessions, there are different facets to this whole process of digitization. So, when we look at it at the most basic or fundamental level for a clinician, it's about having an electronic medical record. For the radiologist, it's about having a PAC system. So there are, and then you have the whole AI thing, and there has been a lot of work that Apollo has done in the AI space, right? So we, for example, now have our AI-based cardiovascular risk calculator, which has used the abundance of data that Apollo has on cardiac patients over the past 40 years, and then applied AI-based algorithms to come up with a cardiovascular risk predictor that is useful for the Indian population. So when you see, and then of course we have Apollo 247, which is our patient-facing app, which allows you to do everything from virtual consultations to ordering medicine. It also allows you to store your health records. So most Apollo patients will have access to a PHR that is enabled by the 247 app. So if you look at the whole ecosystem of what digital has done within the Apollo ecosystem, I think, yes, we are a good way out. The Apollo 247 app, for example, has 10 million downloads. So it's being used with some success. I won't say it's completely satisfactory, but with significant success. Telemedicine has been a success story. But I would like to bring it back to, the core of the whole thing, which is getting our hospitals digital. And when you say hospitals digital, and Mr. Menon is a dear friend, but when I looked at those digital standards, I was thinking to myself, so we have the architects, we have the planners, we have people who put considerable thought into it, but that one line on that standard is 2 years' work. That's how difficult it is. And I will take a specific example on LOINC code, right? He said that we should be LOINC compatible. Apollo, the ecosystem, is 74 hospitals. And unfortunately, because we're a 40-year-old organization, everybody decides to call the same test by a different name. So Satish calls it blood glucose, he calls it blood sugar, and somebody calls it plasma glucose. And to get these guys on the same platform and say, use a common LOINC code is not easy. It actually took us 2 years. So we had like 30,000 codes just for lab tests, and to take away the codes, and this has evolved over time because people kept adding codes as they thought convenient, as their clinicians thought convenient, and so we had a whole lot of work to do to get it loinc coded. Today I can proudly say that we are about 85 to 90% loinc compliant, and that is because we've kind of introduced a policing system that nowhere within the system can you create a code for a new test. There is a central governance mechanism, and unless it comes to them, you will not be allowed to include a code. Just think of how difficult it is to get the clinicians to code the procedures or MRD to code the procedures, right? We don't decide to call it the same way. So you say coronary angiogram, somebody says cardiac angiogram, somebody just says CAG. So we don't know how we've not started yet. We are talking about SNOMED CT, and we are doing some work on it. Hopefully in the next 3 months we will get SNOMED CT compliant, but not an easy task. To get people to use it, it changes the way we think about it. And I was practicing as a clinician, so I'm completely on board with how difficult it is for clinicians to adjust. I'll just make one last comment, and this goes back to the original NABH standards. You know, there's an element there which says every medical record entry should be dated, timed, and signed. And I don't think that there is any hospital in this room or any doctor in this room who will say that every entry in his case sheet is dated, signed, and timed. If the date is there, the sign is not there. If the sign is there, you can't recognize whose sign it is. And then the time may AM, PM is not there. So I really don't know, what people were talking about 24-hour clocks. We are fortunate to get some time on it, and the times don't tally. So patient comes to ER at 10:10, right? But the admission is showing 8 a.m. So now I have this difficulty of reconciling the time which my electronic admission system says 8, but the ER record starts at 10. Where did those 2 hours go? Is something that all of us face. So I just want to say the challenges are there, but we are committed to working on the digital path, and maybe if I get some time, we'll share the benefits we've got from digitizing. Thank you, Satish.
Thank you. Dr. Ayyappan, last year, I think in our MedClave 2022, you spoke about digitization in hospitals. So, how has this given benefit to your hospital as an organization and, of course, patient care?
Thanks to OCA for the opportunity. First of all, digitization, I think, is definitely a much needed tool. The main issue is that it is so much fragmented. So very difficult to adopt them and integrate right now. I feel the chief issue is like so much of technology is available. Everyone talks about AI, everyone talks about ChatGPT or all the new tools which is available. But those who are talking this, they are not completely aware of the actual problems the clinicians or the patients are facing. So I feel it should be more medical professional driven when the software or the solutions for digitization. If that is there, then the real problems can be well understood, and it will be much easier to work. So as practicing clinicians, we feel it's helping us in many ways, like collecting data and all is there. But most of the softwares which we see now are all data centric. They all want to collect data. They want to work with the data. They want to, like say the supply chain management or the CRM tools. They all want to do with the data. They are not exactly patient centric or medical care centric. So if we have a proper model which is fully integrated with this thing in mind, like our hospital's main motto is to make great healthcare affordable. So to that mission, so we have tailored our needs. So we spoke to so many vendors. In fact, we have right now tied up with 32 different vendors to integrate with our own software. We spoke to different companies, and it's very difficult for us to make them understand. So every time we have to tell them this is actually what is needed, and then they come back and they make software solutions and it takes at least 1 or 2 years of time. And meanwhile, things have gone to the next level. Our needs are changing now, so it needs to be very much dynamic. So now, in fact, we are making our own software solutions, and we're creating all the tools within our software now. So that way, it will be one wholesome and integrated approach from top-down approach, where the patients feel it is much more really friendly. So suppose a patient comes to uses the software and or comes to the hospital, and we say for your digitalization or for your telemedicine purpose you want to charge you some money. Okay, some finally we need to pay this software company some fee. So we need to pay only from our patients. We don't have any other source of income. Patients finally pay whatever is needed. Patients are going to pay. So if that burden is there, like say for example some 250 rupees you need to pay for the software, then patients will be obviously questioning. I am coming for a simple cough and cold. Why I need to pay this additional money? Can't your doctor simply examine and give a medicine? Why this fuss about this? That you're going to collect your data, you're going to use it for clinical research. Only this point patients are going to think. Like if there is a standard solution, I was just speaking to the joint director from NHA. So if there is some standard solution which is available, which where everyone can work along, like maybe like an open source software, and for all those basic purposes, things can be much easy to access. And for the specialized tools, like where you need some real hard work, like you want some AI tool and all, therein wherein there's a pay per use model is there. That way it may be much more easier to adopt. The other thing is the doctors. We find so many of your senior doctors, they all see it is very good. The software, you saw that urologic demo, and AI based 3D software for the kidney stones. It is very useful, but finally the doctors really don't want to sit and look at the reports or the exact images. So it's just one small beneficial purpose. It's not having a wholesome effect. So
Yeah, I agree with you. I think probably this gentleman has done a CT scan of the abdomen, which probably has got radiation and effects of that. And probably you would have done off with just an ultrasound to diagnose this, and it would take a little less time and money also. Yeah. Right. Thank you, sir. Dr. Prabhakar, we are not from the city. We are from tier 2, tier 3, and tier 5 areas, I think. So, what are the challenges you have in training your staff, or probably doctors also? Doctors are even worse than the nurses. At least they listen to you. So, what are the challenges you faced, and how did you try to solve them?
See, basically in a tier 3 city, um, we all evolved from beginning writing our registers for the UHID and other things. A lot of manual mistakes used to happen. So, and our hospital, we started, with NABH, initially entry level, then we got full NABH, second cycle now. So that is one thing which I feel, because when we talk about NABH, everybody thinks that it is only for corporates or big hospitals or in the city, not for the small hospitals or mid-segment hospitals in tier 2, tier 3 cities. That is wrong, because in tier 2, tier 3 cities, the NABH actually gives more benefit than the corporate hospitals, because corporate hospitals are already there, the systems are formed. But for a small and mid-segment hospital to come out without any problem in the litigation and other things, it really helps. So that is how we started working on it. And it is our software was like, digitalization was custom made. And every time when we wanted to train these staffs, so that was a big challenge, because you don't get too much educated people in tier 2, tier 3 cities. So we initiated a program where each and every part of the software, like if you suppose a patient comes, the registration module, so it will be opened and each and every point will be shown as a video in the computer screen. And there are a lot of softwares where it will record as a video. So for that video, we had dubbed a voice explaining what it is and what is this registration, how to register for a new patient, how to register for a review patient. So this type of videos we have made for the entire software. So which, we keep it for the newcomers, because the attrition, if it happens, then for the staffs to be trained, it takes long time. That is one thing. Second thing, the person who is going to teach the newcomer may not be in full form that day, will not give all the inputs needed. So there will be a lot of mistakes. So this is one challenge which we really made. And the second one is implementing NABH. We thought, okay, we'll use this to improve our patient care and things like that. But we have evolved with a lot of negative aspects in this digitalization. For example, in our marketing meeting, we decided that any patient getting discharged, we will send a SMS that thank you for visiting our hospital, have a good health and other things like that. But unfortunately, we didn't have that because this is all evolving in a small hospital. Initially, when we started giving this message, it went to the dead patient also. When the patient dies, on the day of death, it goes again. So then we have to modify that. And then came a very big advantage in digitalization was the pharmacy, because a lot of stock, unwanted stock, reorder level. There are a lot of things which really it helps us, because otherwise we'll be keeping some stock worth 10, 20 lakhs lying around there, and that will be a very major expense for us. And then again implementing this early warning score, we try to implement it, and automatically when the score goes up 2 to 3, it SMS the consultant. But then a lot of other consultants also will be there who is not relevant. The primary consultant will be different, the other consultant. So we evolved on this, and slowly, even in the last inspection of NABH, we had a problem that it's very difficult for doctors, as he told, doctors doesn't listen, and writing in capital, writing the generic name, but particularly with combination medicines, it's all a very cumbersome procedure. So what we did was we used the software, and we have to just select from the template. Again, typing the number, again mistakes came. When you type the UHID, again the wrong UHID was typed. So we used barcode reader. So these are the evolutions which we had, because our software was self-designed, and we had to evolve on that, and we have reached this. So for training purpose, it's very important that, because we don't have much resources as other hospitals have, so we, with limited resources, one time just recording with video and audio, and that will help our newcomers to learn more. Thank you.
So you really done a good job out of it. So congrats on that. Coming to resources, Dr. Mukesh, so this kind of digitization requires a lot of hardware. I know you have invested in a robot, so there's a lot of investment there. But this digitization also requires a lot of hardware, software. Then you have antivirus software, AMC, maintenance, and all those things. So do you think this is a problem for us and to run this kind of digitization?
Thank you, sir. The moment I started my hospital, the first thing I bought was 20 computers to all the corners of my hospital, because I just gambled with many softwares, and I have lost few lakhs of rupees in investing in deciding which software is the best for me. And then finally I decided currently I'm using a platform which is a cloud-based platform. Fortunately, it is ABBA compliant, and it has all the features like that. The problem comes in implementing, training our own staff, like how to enter the data. And when we ask them to use the computer to enter the data, sometimes they enter the data not on the patient side. So it's a practical difficulty. Then we thought of introducing a tablet-based system. So we are just currently investing in some of the tablet system, not entirely. We are just trialing with 2 tablets and allowing our staff to use it by the patient's bedside to enter the clinical data. And also for our doctors, we are trying to use I have the habit of using a lot of clinical written notes. For that, if I start typing, then I will be seeing the monitor, I will not be seeing the patient. Correct. That is the greatest difficulty. So I devised a platform so that I can see the patient and write it digitally, and then it's automatically uploaded in my software. This is what I am doing.
It is scanned or it's converted?
No, sir. It copies in my own handwriting, so that for my future reference that will be useful. For tablets and prescription, you can select a menu from the drop down menus and you can use it. And many times what I feel was when my software is ABBA compliant, but my patients are not compliant. When I ask them Aadhaar number, literally many patients are fighting as if we are
data.
We are securing their data. This is the major problem we have when we see it in the rural side. I think the government has to make a public announcement that it is mandatory to give the Aadhaar card to all the private hospitals also. Not
Correct.
only it is the government hospitals, it is also mandatory to give it to the private hospitals.
Correct. Thank you. So now that, ma'am, Dr. Rohini, you have introduced 80% of digitization in your hospitals. Suppose some downtime occurs, something happens to the software, cyber security alert, something. So what happens? How do you handle it? You must have had something like it. So how did you handle it?
I think over the past few years, I mean, this is in the distant past, we did have, shutdowns and systems hanging, and we always had a manual backup so that we could do it, make the systems run. I think if I should say, post COVID, I think our systems have stood up rather well. So there's some redundancy which has been built into it. Most of our data is now sitting on the cloud. Actually, the migration to cloud has almost completely happened, which is good. The vast majority of the systems that we use are built in house. We do use some stuff from outside. Maybe, for example, we use Oracle and we use something for HR. So there are some bits and pieces which are plugged into our hospital ecosystem. But by and large, most of the clinical stuff is built in house. And our ERP, that is the enterprise thing, is actually very robust. Over the years, we managed to make it robust. So we fortunately not had too many challenges either on the cyber security front so far or on this, but it remains a risk. And I think in the earlier discussions they were talking about the personal data privacy. See, one of the things that really worries us is that as clinicians, I think we are also not completely conscious or not extremely as careful as we should be in putting our patient information out there. Even today, we were having a discussion with one of the units, and they were using a tool to track ventilator associated pneumonia. So they're using the CDC tracker that's available online, right? So you put your patient data there, and then it just tells you if it is a ventilator associated pneumonia, which is good. But then the concern for us is you now put your patient data, however anonymous it may be, outside. So that remains a concern for us. Many of our clinicians, for example, if I could take an orthopedic example, the Oxford knee score, right? We're putting our patient data into that online calculator. There's no way that you can do it otherwise. If you're using Apache, again, you're using an online calculator. So those things worry us as to how this data is sitting out there and whether it will be utilized or not. So we need to do a lot of discussion around this. The other thing which worries us, and within Apollo, we of course have a repository for patient data. That means patient samples, which may be tumor, tissue, histopathology, or blood samples, which we have taken some consent for the patient and kept for further use or for research. Now with genome sequencing becoming so widely used, you will now have access to data which we don't have a complete understanding of how this data can potentially be used. So that is another worry for us, as more and more of our patients, you move to whole genome sequencing, and we have a large amount of genetic data which is sitting there. So these are some concerns which we have not addressed, but I think we are waiting for the details on how the PDP comes out and what we will need to do as an organization to adjust to that. If I may be just allowed one advantage, which is a big advantage for us for using digital systems, and that is for us to track the quality parameters. For those of us who've been doing NABH for 20 years, we know how difficult it was when we were using pen and paper. You weren't even sure if you reported all the mortalities in your hospital, and one or two would get missed. Right now, these systems have become a lot more foolproof. So whichever NABH indicators or quality indicators that we use in terms of time, process, structure, outcome, this has become a lot easier. It has become a lot more robust, so that our time can now be devoted to analysis and doing a CAPA and implementing an action plan. So that's been a big, big plus for us in using digital systems for documentation.
So I think we'll just have some closing remarks from everybody. I think we are out of time. So Dr. Ayyappan, interoperability, that is you have 2 or 3 systems, and how do they communicate with each other? Do you have any difficulties with your software, current softwares?
Yeah, definitely that is one key area of concern, interoperability, and it takes so much of time in getting this done. Some of the softwares are really easy to integrate. We found like we can integrate in 1 or 2 days, but some take too much of time. We have a fantastic digital strategy team. So they're able to communicate, and if it's extremely difficult, then we straightforward we say no to that solution, even though it may be really beneficial. If it takes too much of time and if it is giving inconsistent results, then we don't go ahead with that. Uh, I think definitely digitalization is indispensable. We cannot work without that, no doubt in that. But definitely, I think it should be in a much more organized way. And we see the way NHA is now going ahead. Definitely, just like UPA, I think UHA will be there, and it's going to transform in near future.
Thank you, sir. Dr. Prabhakar, I think being such an NABH person, digital NABH must be a walk in the forest for you. So, what is your take on digital NABH? Now, I got my head was spinning seeing those slides from Dr. Meena.
No, it's not really not like that. The thing is, most of the things we are doing already. At least I think the mandatory things which are core standards or core objective elements. I think most of us are doing at least for 70 or 80%. The remaining part may be a little difficult, particularly in the ward when you want to really enter the data digitally. So there might be a challenge in that. But nowadays, like there's a lot of tools which have come. For example, sir was telling about writing notes and storing it. So we have innovated one thing where we just record it, voice recording. We do it in the patient whichever file is there in the digital file. We just voice record, like in the theater. Once the case is over, we just dictate operation notes there. And there are softwares now recently which has a good, initially it was not good dictation converting into this, but nowadays it's better, and we can use our ward clerk to translate that into a typed data and enter in the software. So this is going to be the future. There's no doubt about it, because digitalization is going to be the future. And when I was initially working on this NABH, full NABH, about 7 years, 8 years back, that is the time when entry level was first introduced. So I just saw that most of the things were amicable, and I applied, and I was the first hospital from Tier 2 city, which first hospital in India to get entry level NABH. And I was called to Delhi and offered the first entry level NABH. And subsequently, then the standard went up, expectation of the patients went up, so I was forced to go into full NABH and subsequently. So digitalization, I don't think whether it is in a corporate hospital or a small hospital is going to be a very big challenge. Only thing is we need some more manpower and investment on like pad or nowadays you have a small phone also, like what we have in the hotels and others where they take the order. So similar, like small phones are available which can be used, and so that is our future, and it is inevitable, that has to be there. And secondly, since we have got representation from age health national health organization, I would like to request them, as sir has already told, because we are facing a lot of problems in assessing the genuinity of any patient. For example, in a transplant, we are on a renal transplant program, and we are little it's very difficult for us to whether know the patients are coming, who are coming are real patients, or they have a fake Aadhaar ID or whatever it is for their relationship and other things. Similarly, for infertility, if you say oocyte retrieval, a lot of problems have come. So if we are given an access for verifying Aadhaar, that will really help us, because we don't have any other method to verify. If they think that it is going to be a challenge for them giving with a privacy problem, at least you can give a portal where we can send these details to you. You can verify and say it is correct or not. So something like that, it should happen. Only then hospitals, really will be in a proper space to identify the real patients. Thank you.
Thank you. And last word from you, Dr. Mukesh. See, a lot of software developers are also here. What is your message to them as a user?
Yes, sir. The software to be developed should be very user friendly, and there should not be any glitches or should not be any hidden links into that. It should be like interoperability. Like you said, it should be like we should modify it n number of times, and the staff who we are going to use is not a technically very savvy person, so it should be like very easy. And we should also design a patient based app where they could fill all these details themselves, so that like we can reduce our work. And it should integrate with all the existing machines within our hospital, so that the data is automatically being captured into the patient's UHID. So that is why small request to our app developers. Thank you, sir.
Thank you. Thanks to all the panelists. We'll call it a day. And I think it was very interesting. We had some positive points as well as some points to be discussed. Thank you all. We'll have any discussions offline. We'll move on to the award ceremony, please.